This session is sponsored by Novartis, and it gives me great pleasure to introduce our speaker, Dr. Sachin Jain, medical oncologist from Udaipur. Over to you, sir.
Thank you very much. So, in the continuation of the new molecules, as sir discussed about the new molecules for HER2 receptor, previously for hormone receptor positive patients, only 4 drugs were there, and after that we have to use chemotherapy. But with the discovery of the new molecules, now there are few medicines also available for hormone receptor positive advanced breast cancer. So, in this session we would like to getting real with Ribociclib. This is the bridging the randomized controlled trial and real world evidence universe with evidence across 8,000 patients. So, when considering options for advanced breast cancer, the majority of the oncologists and women surveyed report that overall survival is their treatment goal. Everybody wants to survive more, and overall survival is the gold standard endpoint for efficacy measures in the oncology trials. So, in the clinical trial endpoints for the approval of cancer drugs and biologics, it is defined as time from randomization until death from any cause and is measured in the intent to treat population. The overall survival is considered the most reliable cancer endpoint, and when studies can be conducted to adequately assess survival, it is usually the preferred endpoint. So, about the new molecules, the Ribociclib is the CDK4/6 inhibitor, and it has shown the statistically significant overall survival across all 3 phase 3 trials of Ribociclib, that is the Mona Lisa 2, Mona Lisa 3 and Mona Lisa 7 study. The Mona Lisa 2 conducted on post-menopausal with aromatase inhibitor, 3 conducted on post-menopausal with fulvestrant, and Mona Lisa 7 trial include the perimenopausal patients with aromatase inhibitor, and found that all 3 studies showing there is significant overall survival with the use of Ribociclib. So, median overall survival, we can see the 5-year when given as first line across endocrine partners or menopausal status, the addition of Ribociclib to first line endocrine therapy increased by median overall survival was increased by 1 year. That is, in the first menopause in Mona Lisa 2, it is from 51.4 month to 63.9 month, that is benefit of 12.5 months. In the Mona Lisa 3, from 51.8 month to 67.6 month, that is the benefit of 15.8 months, and in the Mona Lisa 7 in the perimenopausal female, 48 month to 58.7 months, that is a 10.7 month overall survival benefit. So, real world evidence with Ribociclib demonstrates results that are consistent with the phase 3 RCTs, and in this the complement and Ribana trials are included. These trials are complement is the phase 3B international study of Ribociclib plus letrozole as first line therapy in the men and women who have not received prior endocrine therapy for hormone receptor positive advanced breast cancer, and the Ribana is the ongoing prospective German study of real world efficacy of the Ribociclib with AI or fulvestrant or endocrine therapy or chemotherapy as first line treatment in patients with hormone receptor positive HER2 negative advanced breast cancer, and they have both included more than 5,800 patients. So, study design covered more than 5,800 patients from real world practice, and in the complement trial the planned number of patients were 3,000, but final enrollment was reached more than 3,000, that is the 3,246 patients. Men and women with hormone receptor positive HER2 negative as advanced breast cancer were included, and no prior endocrine therapy for advanced breast cancer. These are the inclusion criteria. With the echo performance status was 2 or less than 2, CNS metastasis permitted if stable for more than 4 weeks, and they have given Ribociclib plus letrozole, and treatment discontinued till progression. The primary endpoint in this study was safety and tolerability, and secondary endpoints were time to progression. overall response rate, clinical benefit rate and patient reported outcomes. While in the Ribana, they have planned to enroll 3020 patients, and currently they have enrolled 2500 patients. So, about the complement trial, there are diverse subgroup population representative of real world practice, and they have include subgroups more representative of real world practice and not well studied in CDK4/6 inhibitor randomized control trials they have included, and they have included the patients treated with prior chemotherapy for advanced disease, patient with ECOG performance status 2, patients with stable CNS metastasis, premenopausal patients and diverse race and age compared to the RCTs. And they found the safety profile was predictable, it was manageable and it was similar to phase 3 RCTs, and events reduced with prolonged exposure as in the RCTs. We can see that the events reduced as we give prolonged exposure of the medicine to the patients, and the adverse effect, serious adverse effect, even fatal serious adverse effect, adverse effects leading to discontinuation and adverse effects leading to dose adjustment are similar as in the randomized controlled trials. The efficacy was the prolonged TTP with a high event free probability. The event free probability is 12 months is 75%, at 24 months it is 55.7%, and at 33 months it is 39%. And under an exploratory analysis, the median PFS was 26.7 months with the even in the real world scenario. There is also improved response in patients with measurable disease. We can see that clinical benefit rate in measurable disease is 69.1% and overall it is 17.7% in the involved population. So, the CDK4/6 inhibitor and CNS metastasis in phase 3 randomized control trials, they have included very few patients with the CNS metastasis. In the Mona Lisa 3, they have included 8 patients, while in the other studies with the other CDK4/6 like Paloma trial, they have included 2 patients and 5 patients, and in Monarch trial, that is with abemaciclib, they have also excluded the patients with CNS metastasis. While in the complement trial, which is a phase 3b real world study, they have included 51 patients with CNS metastasis, which is the in routine practice. We can found patient with CNS metastasis. So, there is consistent efficacy across the subgroups of clinical interest. The overall the TTP is 27.1 month, and we can say the patient with CNS metastasis, the TTP is still not reached, while in other patients like prior chemotherapy, the TTP is 18.4 month. With ECOG performance status 2, the TTP is 19.5 month. In the visceral metastasis and prior chemotherapy, it is 13.7 month, and in patient with visceral metastasis and ECOG performance status 2, it is 18.8 months. Also, the patient reported outcomes like emotional and functional well-being scores are also maintained in the patients while on treatment. We can see the overall the functional and emotional well-being, social well-being and physical well-being is also maintained in the real world scenario with the ribociclib. So, this first was the complement trial, and the second is the Ribana, which is in German ongoing prospective and non-interventional study, and it has included 2598 patients in the study, and it has also found that the median PFS with ribociclib and aromatase inhibitor or fulvestrant, it is 37.1 month, while and with the endocrine therapy alone it is 25.7 month, and with chemotherapy alone it is 15.3 months. So, there is clear cut benefit of giving ribociclib in the advanced breast cancer along with the hormonal therapy. The safety and treatment, the safety profile was similar to that observed in the Mona Lisa studies, and the most frequent treatment emergent adverse effects in the ribociclib plus AI or fulvestrant cohort were neutropenia, then nausea, fatigue and leukopenia, which are manageable. The outcomes reported in phase 3 trials are achievable in real world practice also. The median PFS in the complement is 26.7 month, in the Ribana it is 37.1 month, in the Mona Lisa 2 it is 25.3 month, in the Mona Lisa 7 it is 27.5 month, and in the Mona Lisa 3 it is the 33.6 month. So, these are comparable with the RCTs. So, about the guidelines recommended for the ribociclib, according to the NCCN, the aromatase inhibitor plus CDK4/6 inhibitor like abemaciclib, palbociclib and ribociclib are indicated in the first line, or fulvestrant with CDK4/6 inhibitor are recommended. And in the phase 3 randomized control trial, ribociclib plus endocrine therapy has shown oral survival benefit in the first line setting. This is the only medicine which is showing oral survival benefit. So, the ribociclib RCTs with perfect ESMO MS MCBS score, the ribociclib is the only CDK4/6 inhibitor to achieve a score of 4 in first line and second line post menopausal patients, and 5 score in the pre and perimenopausal patient with HER2 positive and HER2 negative advanced breast cancer. In this trial, in the Mona Lisa 2, it is MCBS score is 4, in the Mona Lisa 3 it is 4, and in the Mona Lisa 7 it is 5. So, only therapy achieving a grade of 4 or 5 are considered to indicate a proven clinical benefit. So, these 3 CDK4/6 inhibitors are not similar, they are different. And what are the difference? The inhibition of CDK4 target breast cancer cells, while inhibition of the CDK6 may lead to hematological adverse effects. Means the clinical benefit as per cancer is only by the inhibition of the CDK4 targets. The ribociclib Crixana is the more selective to the CDK4 than 6, while palbociclib inhibits CDK4 and 6 equally, and the number of off-target kinases inhibited by ribociclib are 4, by palbociclib it is 13, and by abemaciclib are 52, and that is why their adverse effects are different. And inhibition of off-target may lead to adverse effects like GI. In abemaciclib shows a different adverse effect profile with more diarrhea, venous thromboembolism and interstitial lung diseases. The palbociclib has equivalent CDK4 and CDK6 inhibition, while both ribociclib and abemaciclib are more significantly potent, more potent for CDK4 as compared to the CDK6. The ribociclib exhibits higher selectivity for CDK4 and more drug available to the penetrate and act on tumor cells. So, as compared to the palbociclib, it is more potent for the CDK4 8 times, and drug availability is 22 times more as compared to the palbociclib. So, in the summary and conclusion, the outcomes from RCTs can be replicated in real world experience. Guidelines recommended early uses of CDK4/6 inhibitor for patient with HER2 positive and HER negative advanced breast cancer. The ribociclib is the only CDK4/6 inhibitor to demonstrate longest yet median overall survival of 63.9 months from the Mona Lisa 2 study versus 51.4 months with letrozole alone. The significantly improved overall survival across lines of therapy like endocrine partner and menopausal status, achieve an ESMO MCBS score of 4 and 5 across all the phase 3 studies, and demonstrate similar efficacy and safety in 5,800 real world cases. So, the ribociclib also has demonstrated consistent efficacy across patient subgroup including CNS metastasis, visceral metastasis, chemo treated, and even on ECOG performance status 2. The 3 CDK4 inhibitors are different on the basis of CDK4 selectivity and off target basis inhibition and free drug concentration, and potential impact on observed differences in efficacy and safety. So, this is all about the real world scenario with the randomized control trial for the ribociclib.
Dr.
Thank
Sachin, small
Yes.
question. Can you tell us the cost of this treatment, please?
The cost of this treatment, ma'am, ribociclib with the help of patient assistance program, it is approximately 40 to 50,000 costing a month. Yeah, And by the cost wise, nowadays in Rajasthan, cost is a matter only for the BPL patient. All the RGCS patients are free to get this medicine, and other medicines are free for.
This is approved in Rajasthan.
Yeah, it is approved, and we are using this medicine in RGHS patients.
What gross side effects you observed in your practice?
The majority of the patients are present with neutropenia, ma'am.
Manageable. Okay.
Otherwise, the patient
Diarrhea?
tolerate well.
How bad is diarrhea?
As we are using ribociclib, not abemaciclib, so we are not getting patient with complaint of diarrhea. They are mainly with the neutropenia and thrombocytopenia, ma'am.
Thank you.
These mainly have, ma'am, yeah, neutropenia is not that severe that what we see in the chemotherapy. So most of the patients just require a discontinuation of the treatment for a few days gap. So they will recover most of the time on its own. Without any neutropenic infections are rarely noted, less than 1%. No treatment for neutropenia.
If patient is with fever, and then we use GCSF,
rarely it's less than
and
1%. Less than 1%.
And with the 7 days gap, generally patient recovered. Thank you.